Welcome to CRC Health Connect. I'm your host, Dr. Siu-Him Chan. We're very fortunate today to have an esteemed rheumatologist, Dr. Kazem, to tell us more about osteoporosis. Welcome, Dr. Kazem.
Thank you for having me.
So what is osteoporosis?
Osteoporosis is generally a state of weak bones. We are concerned about it because weak bones are more susceptible to breakage, and breakage of bones is painful and causes disability.
So what kind of patients are more likely to have osteoporosis?
There are a number of risk factors when it comes to osteoporosis. We generally think of older patients. In case of women, postmenopausal. In case of men, if there's been any specific types of medications that have, for instance, been used in prostate cancer. In some women, medications that can be used in breast cancer treatment can cause bone loss. In general, the patients who are subjected or are treated with certain types of medications, patients who have had vitamin deficiencies or nutritional deficiencies, and patients who have had other metabolic disorders that has interfered with their ability to absorb calcium and vitamin D or regulate their bones, they're at risk of osteoporosis. And actually, that includes patients with chronic kidney disease.
So are these patients screened in a sort of a routine fashion then?
So universal screening is very controversial, and we know that it's certain risk factors, including the patient's age and what medications they've been on, what's their past medical history. So we look at each patient on a case-by-case basis, but it's very important to have osteoporosis and bone health on the mind, especially with patients with these risk factors.
And if these patients are to be screened, what kind of investigations are required?
So we generally start with a bone density, which is basically a special set of x-rays that look at your bone density. And the general criteria for bone density scoring, a T-score of minus 2.5 or less, so meaning minus 2.6, minus 2.7, and so on and so forth, is diagnostic of osteoporosis. Now, we should remember that this is not required for making a diagnosis of osteoporosis. So if there is a patient who has had a fall from standing height and has fractured, or a patient who has had any other quote unquote fragility fractures, these can be fracturing your toe by just stepping onto your shoe, or fracturing a vertebrae. They're often referred to as compression fractures or wedging. These are all considered compression fractures, and they are diagnostic of osteoporosis, as they indicate to us that the bones are weak and breakable. In such cases, we actually don't need a bone density to establish that diagnosis. Once we establish the diagnosis, we want to make sure there are no other causes of loss of bone health. So osteoporosis can have secondary causes such as hypo or hyperthyroidism, there's hyperparathyroidism, and again, a number of other disorders, inflammatory arthritis. We know that patients with inflammatory arthritis are more at risk of osteoporosis, and both by the virtue of their disease as well as the treatments that they get. A lot of them get steroids, which in themselves can induce osteoporosis.
Mm-hmm. So if a diagnosis of osteoporosis is made, what kind of treatment options are available?
So in BC, we have about 3 or 4 different types of treatments. We have to complete the investigations for secondary causes first to see what is the cause of loss of bone health. Generally, we want to make sure vitamin D levels are adequate and there is no other metabolic causes. Obviously, if any of those are the reason for osteoporosis, we go after correcting them. If there are no secondary causes found, and this is, the most commonly seen type of osteoporosis. Then we have anti-resorbing medications as well as anabolic medication. Now, in literature searches and based on evidence, we would like to use an anabolic agent, meaning an agent that builds bone first in order to treat osteoporosis. However, our access to these agents are limited by funding, and they're mostly having to be patient self-funded in BC. So for really practical reasons, we have to start with an anti-resorptive. Generally, these are bisphosphonates, either oral, that can be weekly or monthly, or IV, which is annually. And we generally try to treat the patients between 3 to 5 years. We get a bone density at the beginning of the treatment and kind of subsequently in 2 to 3 years after to see the effect of therapy. There is another anti-resorptive called Prolia or denosumab. It is a monoclonal antibody that signals the bone in terms of preventing it from resorbing and melting. The very important thing with anti-resorptives such as Prolia is that because they are messengers and they tell the bone what to do, it's very important to be on time for them and not miss a dose. If they are planned to be stopped, they need to be followed by bisphosphonates, which stick to the bone, and they kind of just paint a layer on top of the bone and prevents its further loss. Most recently, we've had approval of another agent called romosozumab, which is both a bone builder and prevents bone resorption. So it's both an anabolic agent and an anti-resorptive. This is a monthly injection for 12 months, followed by another anti-resorptives. And lastly, we have teriparatide, which is a daily injection, and we often use that for 2 years to build bone and follow that up again with another anti-resorber to make sure that the bone that has been built is maintained.
Sounds like there are quite a few treatment options. So, Dr. Kazem, would you recommend osteoporosis to be managed by the primary caregivers, like family doctors and/or nurse practitioners, or should these patients be seeing a specialist like yourself or endocrinologist?
A lot of primary care specialists are, in fact, managing their patients and their osteoporosis. The most important aspect when it comes to bone health is to really have it on the mind, because often we find that there is a lot of osteoporosis in the community that hasn't even been picked up or even thought about when the patients are started on certain medications. Examples include patients with COPD or asthma who are chronically on inhaled as well as oral steroids, and no one really kind of thinks about the long-term impact of this, or patients, again, within my subspecialty, the polymyalgia rheumatica or giant cell arteritis, who are all started on prednisone, but again, no thought is given to management of their bone health in the long term. So it's really, again, not very practical to say it's your job or my job or the primary care, but whoever thinks of this and whoever looks at the patient's medication profile and past medical history, again, if the thought crosses your mind, just mention it in the consult note. And if there's any questions or any concerns, if you're not even sure, that's what we're here for. So we encourage referrals. With any questions regarding bone health, for review of bone health, or if there are any concerns. We certainly encourage referrals if there are any fractures. So again, fracturing is not part of normal aging. And if there is minimal trauma involved, the patient should be investigated for osteoporosis and potential secondary causes.
Great. That was tremendously informative. Thanks so much for your time.
It's my pleasure.
We'll see you next time.
Take care.